want to just welcome everybody and hope you're doing well and enjoy this terrific meeting. We're going to talk now about one of the big challenges we all face in practice, because when we leave meetings like this after learning advances in management of our patients, of course, the rubber meets the road when we try to get our patients the therapies that we want them to receive. And I'm delighted to share this presentation with a PharmD from the University of Chicago, Shivani Patel, who will help us understand this a bit more. You can see our disclosures here. Yes. Should I go back a slide? I did a separate fellowship in clinical ethics, and I teach the doctor-patient relationship to the medical students. And one of the things we always talk about is this patient-doctor or patient-provider relationship, which traditionally has been a dyadic relationship in the context of a disease, where we're together fighting the condition that's causing their suffering. Unfortunately, the reality of this situation has changed, where we now have to admit that what we decide we might want to do for our patients is often encumbered, or at least must be considered in the context of how we can get them the therapy that they need. So the two major areas of IBD care that we've talked about and I think have evolved to the point where they're critically important are quality, which is another topic, and there's certainly been some terrific work done in that area, and access. And these are inextricably linked. You can't provide patients with what might be viewed as the quality of care they need without being able to get them that care, whether it's in the form of expert providers or, of course, in the treatments that go along with such care. So as we talk to our patients and make our recommendations, it's always couched in the final statement, which is, let's see if we can get that for you, or how will you pay for this, or what will your payer allow us to do. It is a reality that we all know well, that although we've made great progress in the way therapies work for our patients, these are very expensive treatments. This is the costs of some of our available biological therapies listed here for you, so you can break it down and understand, and I'm sure there's some variability in this, but it goes without saying now to recognize that at least the way these are charged and the wholesale value and cost of these therapies really limits the understanding of how much our payers can tolerate it, how much society might even be able to tolerate it. And what has been considered to be a rare disease, that of IBD, and it still is labeled as such, certainly has its share of quite expensive therapy, as well as the whole discussion, which is not part of this presentation, on indirect costs, which have to do with lost work and lack of productivity related to such. There are some opposing forces in the insurance coverage decisions, so that we don't focus this all on just being anti-payer. The reality is that they have to balance providing the care to the greatest number but with lesser benefits, as opposed to providing the most care to a smaller number. It's really about sort of a Machiavellian model versus trying to figure out who gets what when, a rationalization model. And there's the obligation to provide care versus the obligation to the shareholders of insurance companies, private companies, to be profitable. The necessity to embrace cost-effective care versus what they consider experimental. We often see that term come up in denials. What we might believe are the established standard of care practices compared to what is available in evidence. And we've seen some stark contrasts between the grading of available evidence versus what we think is the advancing standard of care. And these don't often align in real time. And that's a challenge for us as well, especially now that payers look to those guidelines and the level of evidence as ways to determine their policies and their approvals or denials of therapies. And we also, of course, understand the payer and provider or patient and provider expectations for coverage versus the reality. It's not necessarily wrong that payers deny coverage of certain therapies. That's their policy, and that's what goes along with having a private insurance company. They have policies and they have to try to make decisions. So we always think that everything they deny must be wrong. What's wrong is when it's counter to what is safe, and what's wrong is when it's counter to their own policies, if they're inconsistent. And what I think is consistently wrong is when the communication techniques and the availability of making decisions and having a real-time communication for a sick patient is delayed and inefficient. We did a survey of U.S. providers related to payers and communication with payers, and we presented this at DDW last year. And of this online survey of 158 gastros, they told us what you all know. A lot of time in your offices is spent communicating with payers and trying to get pre-auths and re-auths. In fact, if you look on the left, the times per day that a practice communicates with payers, some indicated that it's more than 30 times a day. Others said that on average it's between 5 and as much as 20 times a day. Maybe more importantly, on the right is the percent of the time of your staff members that is taken dealing with these issues. And I know I'm preaching to the choir here, but at least 25% of a full-time equivalent person was indicated in 63% of the survey respondents. And you know this, you have these staff members who have to spend time working on all these things. We also published last year a national survey of access to IBD patients. This was run through the Crohn's and Colitis Foundation's mailing list, so it admittedly has some limitations in who the target audience was. But this was, just to put it in perspective, a pre-Affordable Care Act survey. So this was before the ACA was approved and put in place. We asked patients about their access to care, and I'm only going to summarize 2 questions we asked them. One was, has your IBD provider recommended a medical therapy that your insurance does not cover? And 13% said yes, and they gave us some specific therapies. 8% said no, and most said it was not a big issue, which is interesting. But then we also asked, what did you do when your provider recommended therapy that was denied? And we got lots of interesting answers. Not a surprise that a quarter of the patients who responded to this survey said that they went without any therapy. And we know this happens, and they often don't tell us this. And others said that they rationed their therapy, they used less of it over time to try and get it to last longer, or they ended up switching or choosing a different therapy. So no surprise that this is a big issue, and we're now finishing the new survey looking at post-ACA, whether any of these things have changed. So now I'm going to hand this over to my partner here, Shivani Patel. She's a PharmD at the University of Chicago, who is originally from California and did her initial schooling in Oklahoma and then her residency in pharmacy, and has stayed on staff at the U of C. And she's going to come up and teach us a little bit about some of the options available. Shivani?
Thank you, Dr. Rubin. So for the next few minutes, let's focus on how we can overcome the cost hurdles that our patients face, and then we'll talk about how to get patients the access that they need. So this is a process that I use on a daily basis, and I know it looks confusing, because it is. The entire pathway on getting patients the access that they need is very complicated. So let's break it up into the 2 main portions that impact our patients on a daily basis, and that's access and how to get patients the therapy they need, especially when we're faced with insurance denials, and then affordability. So we can't talk about access without talking about insurance companies and payers. So a lot of times, there's about 90% of biologics require prior authorizations. And normally, that's just a part of the process. You have to go through the authorization process. However, when you're talking about biologics and the costs, when patients are denied, a lot of times those denials are inaccurate, and they're based on policies that are based on FDA-approved indications and dosing. And so you have to fight these denials. It's imperative that we fight them and get the patients the care that they need. So I recommend doing whatever it takes to get these patients on the therapy that they require. You know, ask to speak with a medical reviewer, do a peer-to-peer and speak with the person that reviewed the case. If that does not work, submit a level of appeal. Submit the supporting literature and the evidence that supports our justification for why we're requesting the therapy. If that fails, submit a 2nd level appeal. If that fails, you know, ask to have the case reviewed by an independent 3rd-party organization. Ask for an external review for someone to review the case that's not a biased personnel. And if that fails, you know, reach out to the State Department of Insurance. So at the end of the denial letter, there's always information for the State Department. So I've provided the example for the Illinois State Department of Insurance. Reach out to them and let them know if someone can review the case. We have had good luck reaching out to the Illinois State Department of Insurance. And if that doesn't work, you know, do anything that is required to get the patients the therapy. So this is to secure access to care. Once you secure access, affordability is still a concern for our patients. So let's take a look at a few different scenarios for our patients. We can look at commercially insured patients to see what options they have. We can look at Medicare patients, especially ones that have Medicare Part D coverage, and then patients that are completely uninsured or their medications are denied and they don't have access. So for commercial patients, patients that are not a part of any government-funded programs, they have manufacturer copay cards that are available to them. This literally is one of the easiest things you can do as a provider is sign them up online. In fact, I do this on my own, and I print out the copay card and send it to our patients. It takes less than 5 minutes to do so online. I've provided the links here. And your patients will be paying less than $5 a month to get their biologic therapy. A lot of times, these copay cards do max out if patients don't have a good insurance plan, and if that's the case, you can also talk to the drug manufacturers. Pharmaceutical representatives can help assist in these situations. And the copay cards also reset annually, so it's not that once the patient is denied or once their copay card is maxed out, it's not the end of the world, so it's something to look at. For Medicare patients, these patients have a completely different challenge of their own because they are not eligible for copay cards. So patients that are on Medicare Part D plans, they have this donut hole that we all know about, this dreaded donut hole, and things are supposed to get better when they hit their catastrophic phase because they're only responsible for 5% of their copays. But when we're talking about biologics, that 5% is still hundreds of dollars. And so patients often cannot meet their copay for their biologic medication, and then they're stuck without medications. So what can we do for Medicare Part D patients? So Medicare Part D is their prescription coverage, but check to see if they have a Medicare Part B plan, which is their medical coverage. If they have a Medicare Part B plan and they have a supplemental insurance to cover costs for their inpatient visits, you can route some of these patients to get their medications administered in clinic. So ustekinumab and certolizumab are both great examples of this because those medications also come in vials, which can be administered by a healthcare professional. So if your patients are trying to get access to ustekinumab and they do not have, the Medicare Part D plan does not offer them copay assistance, which it likely will not, see if they have a Medicare Part B plan with supplemental insurance that can pick up their costs to get the medication administered in clinic. We often do this for our patients and route them to an outpatient infusion center, and they can then get their medications. The only negative part about this is they have to come into clinic each time, which is often not a problem for ustekinumab because it's an every 8-week regimen. But what about patients that are completely uninsured or they do not have, going through the medical plan is not an option for them, or they just cannot get their medications approved through their insurance? So there are various foundations that we utilize for IBD patients. Needy Meds is one that can link to a lot of other foundations as well. We've had some good luck with the PAN Foundation. The only negative part is that these foundations often don't have funding. So it's something that my medication access coordinator checks on a daily basis to see if there's funding available for Crohn's disease and ulcerative colitis patients. Often funding is not available though. So one of the last resorts that we utilize are manufacturer patient assistance programs. So these are patient assistance programs. I've listed some here. We've had very good experience with a lot of these. So the manufacturer patient assistance programs are good options if your patients cannot, one, get access and their medications are not approved through insurance, or affordability. So these are kind of our catch-all programs. They are often eligibility-based, and so patients have to meet a certain criteria for eligibility. Their household size is part of the process, as well as their income. So patients might have to submit their federal tax returns to show proof of income. However, overall, if patients do not have any other options, this is a great resource to go to. So the entire process is very cumbersome. There are more roadblocks and barriers to the process than there are solutions. And so if this is confusing for us as providers, then how are we expected to allow our patients to navigate through this process? Just imagine how hard this must be for our patients to coordinate this entire care on their own. So what we did at the University of Chicago is we've teamed up and we've integrated a specialty pharmacy into our IBD clinic. And so we have a special team that is dedicated to doing this process and taking care of our patients. So not only is this heavily beneficial to our providers because it's freeing up all the time that they spend doing prior authorizations and appeals and coordinating all these phone calls with payers, but it is tremendously beneficial for our patients because now they have a direct single point of contact that they can reach out to. So our patients have had increased satisfaction as well as they can reach out to us if they have any questions. Pharmacists are able to help them with education, injection training. We follow their medications, we follow their refills. We make sure that they're adherent to their therapy. We also keep track of their reauthorizations, so we can keep track of all the insurance perspective as well. And patients can reach out to us as their physician's office, as their insurance company. We can help them with financial assistance and copay cards, as well as their pharmacy since we supply their medication, and it's been tremendously beneficial to all the parties involved. So if you look at our numbers, you can see this pie chart. So these are the steps that were required to get our patients on the therapy that they required. And you can see that we've had 2 patients of the 691 that were referred to us that were denied therapy. And so 2 patients out of all of them needed to be switched onto another agent, which is greater than a 99% approval rate for our patients. So as you can see, we are very successful. The collaboration is very successful for our patients and not allowing payers and cost hurdles interfere with our patients and what they need. So to summarize, we want to make sure that our patients are insured, and not just insured. We want to make sure that we're getting them access to care and getting through the insurances and third parties for whatever the reasons are, but getting them access to care. And then secondly, we also want to make sure that we're reaching out to manufactured drug programs and copay assistance programs to making sure that their medications are affordable as well. So my takeaway point is to get a dedicated team that can take over this process and really own it. If you have, pharmacy leaders, nursing leaders, social work leaders, reach out to them and make sure that you can get some help because the process is very cumbersome. But if you have a dedicated team that can own it, there's a huge benefit to all the parties involved.
Thank you, Shivani. Now you know how much we love our specialty pharmacists. There's one more slide. Go back. There's one more slide. Can you guys put that back up? I only had one last slide. Is it missing? But I wanted to just publicly acknowledge how much this transformed our practice, and there it is, and thank them for what they've done for us. And I recognize not everyone has the ability to have specialty pharmacies within their own practice, but there are other groups that you can work with and partner with to help try to alleviate some of this. Just as a little bit of a lighter-hearted approach to this, for those following along on Twitter, occasionally I get in a bad mood and do what Peter Higgins called Twitter shaming. But it's not for things that are just denied. It's when it really doesn't make any sense, like when a patient's been on a therapy for 3 years and then their reauth is denied or something like that. And I encourage you to advocate on behalf of your patients, not necessarily using social media, although it sometimes works, but rather by learning what we need to learn so that we can continue this. On the professional side, I think we have an obligation to make our guidelines reflect what we need to do in practice as much as we review the level of the evidence, and to push things along so that there's a shorter lag time between advances in care and what guidelines say, since those are being held to the standards that payers are making decisions. Thank you very much for the opportunity to present together, and I really want to thank Shivani.